As we all know, managing a pediatric patient posted for surgery can be challenging as it requires skill as well as detailed knowledge of anesthetic considerations. Now, we will move ahead with our next topic, that is management of pediatric patient with meningomyelocele for repair by our speaker, Dr. ALKA CHHABRA ma'am. The lecture will be chaired by Dr. Anita Nethe ma'am, Dr. Pramod Jamle sir. I request the speaker and chairpersons to head to the dais. Dr. Anita Nethe ma'am is President Director of Vedant Hospital, Nashik. She's President SAMS and past Vice President of MSCISA. And ma'am has been invited as a faculty in various state and national conferences. Dr. Pramod Jamle sir, the Professor Department of Anesthesiology, Krishna Institute of Medical Science, Karad. Sir has made more than 20 publications under his name. I request chairpersons to introduce our speaker, Dr. ALKA CHHABRA ma'am.
I welcome Dr. ALKA CHHABRA ma'am. She is MD, DNB, MNMS and FIPM and Professor and Head of Gitanjali Medical College and Hospital, Udaipur, Rajasthan. And she has more than 25 publications in national and international journals. And her areas of interest are airway, obstetric and pediatric anesthesia and trauma anesthesia. Welcome ma'am.
Thank you ma'am for introductions. I would like to welcome all in this PG Assembly. I'm very much grateful to the organizing committee of this PG Assembly, and I'm honored to be the part of this conference. So coming to my topic, it's anesthetic management of a pediatric patient with meningomyelocele for repair. So in this lecture, we'll just go briefly into the classification and etiology of neural tube defects that are common, to understand the comorbidities that are associated with meningomyelocele, and to discuss the perioperative care, especially anesthetic considerations in the perioperative period unique to these patients. So neural tube defects, it is also known as myelodysplasia, is the commonest birth defect with the incidence of 6 per 10,000 live births. And spina bifida is a congenital neural tube defect that has multi-system comorbidities. And meningomyelocele is a most severe form of spina bifida. Urgent postnatal surgical repair prevents significant long-term neurological sequelae, and repair of this defect, it poses a diverse range of challenges to the anesthesiologist and require a meticulous perioperative care. So coming to meningomyelocele, it is the most common type of spina bifida, and it is caused by the neural tube defect that occurs in the 3rd to 4th week of fetal development. And because of the failure of closure of neural tube during the 4th week post-fertilization, it causes agenesis of fetal vertebral arch and hence protrusion of the spinal cord, nerves and meninges in the sac. The incidence is 0.4 to 1 per 1,000 live births. And the commonest location of this meningomyelocele is lumbosacral, and it is rarely seen in thoracic and cervical region. Most commonly seen in females, but the recurrence rate is 3 to 8% after one affected pregnancy, and it is associated with various congenital anomalies. So if you see the embryology, the nervous system is from the ectoderm, that is converted into neuroderm in the, under the growth factor which is released by notochord. And this neural plate that is formed folds to form a neural tube, and that fuses, and if it is unable, and it usually occurs in the cervical region, and then it fuses side by side from cranial and caudal end. And if it fails to fuse at cranial end, it causes anencephaly and anencephaly. But if it fails at the caudal end, it causes spina bifida, and it may be open or closed. So if you see the diagram, it is classified into spina bifida occulta, in which the spinal cord and meninges are intact. It is covered by the skin, and tuft of hairs are there at the site. And if the meninges are protruding, it is known as meningocele. And if spinal cord as well as meninges are protruding into the sac, it is known as meningomyelocele. The congenital anomalies that are associated most commonly are cleft palate, cleft foot, various urogenital, genito, and gastrointestinal anomalies with cardiac congenital defects are also seen. And the associated problems that are included in meningomyelocele is Arnold Chiari 2 malformation, hydrocephalus, tethered spinal cord, and latex allergy. Now, this Arnold Chiari 2 malformation is present in 90% of patients with meningomyelocele. It is downward displacement of a cerebellar tonsil and medulla, and because of this, there is a lack of distension of embryonic ventricular system, and because of this, the normal size cerebellum grows in the small posterior fossa, leading to obstruction of the CSF flow, and hence hydrocephalus. That is also seen in 80% patients with meningomyelocele, and this will usually increase the mortality rate. The various risk factors that are associated is the most common is maternal nutrition with deficiency of folic acid, vitamin B12, and zinc. Other maternal factors includes diabetes, obesity, hypothermia, infections. If the mother is taking anti-folic acid antagonist like carbamazepine and valproic acid, environmental and genetic factors includes exposure to various toxins and trisomy 13 and 18, and also the genotype of 510 methyl tetrahydrofolate reductase enzyme. Diagnosis can be done antenatally by USG, in which the inward concavity of the frontal bone is seen, or anteriorly if a cerebellum is seen. And fetal anomaly scan, it is highly sensitive, and it shows third ventricular dilatation with small head circumference. It can the level of neural tube defect can be defined by fetal MRI. Lab investigation shows increased serum alpha fetoprotein levels in the second trimester. And amniocentesis, there are increased assays of alpha fetoprotein as well as acetylcholine esterase, that is a specific nerve enzyme in the amniotic fluid. Postnatally clinical examinations, there is a presence of cystic sac, abnormal bony spine, and disruption of skin contours. Now, when a child comes for the repair, there are two types of surgery that could be done, either prenatally or postnatal repair. Now, the newborns that are born with meningomyelocele, the sac is exposed to the environment, and that is vulnerable to the trauma and rupture of that sac, leading to infection of a CSF and meninges, and eventually neurological damage may occur. So early closure has a better neurological outcome, and this requires urgent surgical repair within 48 to 72 hours. And if not repaired, it may eventually lead to many disabilities and complications like orthopedic, neurological, and genitourinary complications there. So the patient is posted for MMC repair. The preoperative goals should be to establish a rapport with the patient and the parents. Proper review of the history in examination and lab tests could be done, and identify and optimize the associated anomalies and the physical condition of the child at that time, and plan a safe anesthetic technique. Specific history includes antenatal history of any drug intake of the mother, similar defects in the sibling, and birth history like prolonged labor or fetal hypoxia that may be because of a large head circumference. Inspect the defect for location, size, shape, and any CSF leak, and also the curvature of the spine. Now, neurological dysfunctions, there could be signs and symptoms of hydrocephalus or the T3 cord that may develop over the time in the older children. The importance is that the rate of VP shunt placement happens in 80% of patients that have meningomyelocele. So ask for any previous history of surgery of VP shunt in older children, but in newborns, the severity and progression will define the placement of VP shunt at the time of surgical repair of the meningomyelocele. Other manifestations includes Arnold Chiari 2 malformation leading to vocal cord palsy, and thus the child may present with inspiratory stridor, swallowing difficulties, and apneas. Spinal cord manifestations include sensory motor deficits, and these are complicated by the presence of hydrocephalus, musculoskeletal issues, and pressure scores. Neurogenic bladder is seen in 90% of patients, which may lead to, if not repaired, which may lead to renal injuries in the future. Other may be bowel dysfunction in 87% of patients, and orthopedic complications affect the motility and gait of the child. Kyphoscoliosis is usually seen with hip dislocations, and ask for any seizure disorders and the compliance with medications of the patient, and also look for the cognitive dysfunctions. The most important is cardiorespiratory manifestation that may be multifactorial, but if underestimated, it may lead into high-risk post-operative complications, and congenital heart defects in the form of ASD and VSD is seen in 30% of the patients with meningomyelocele. Also, the brainstem dysfunction may lead to atypical response to hypoxia and hypercapnia, leading to post-op apnea episodes. Kyphoscoliosis may lead to restrictive lung disease, and because of poor cough, the child may have recurrent respiratory tract infections. Sleep-related breathing disorders should be looked for, and these manifestations may lead to right ventricular dysfunction in the child. Airway, most important. As a pediatric age group, and anatomical changes that occurs in the pediatric age group from the adult, along with it associated abnormalities of the airway, that cleft palate, hydrocephalus, Arnold Chiari malformation of kyphoscoliosis may land the child into difficult laryngoscopy and intubation. So the preoperative investigation that could be done when a child is posted is a complete blood count, ABO and cross-matching, serum electrolytes, baseline renal functions, urine routine and microscopy, because these are very much prone to recurrent UTI, and catheterization, X-ray chest if a patient is symptomatic, and also rule out cardiomegaly. CT MRI will look for the hydrocephalus, and additional investigation that can be done to the child is baseline ABG, ECG, 2D echo for any congenital heart disease, USG for any structural anomalies, and urodynamic studies. Now, preoperative advice that is given to the newborn especially is that immediately after the birth, till the surgery is performed, the newborn should be positioned in prone or lateral position so as to prevent any damage to the sac, and cover the defect with a sterile moist gauze. Follow the fasting guidelines according to the age of the patient. Keep the child or neonate warm and properly covered. All the equipments, gloves and catheters that are used should be latex free because they are more prone for latex sensitivity. IV access should be given, and continue preoperative maintenance fluid should be given to the child. Antibiotic prophylaxis, vitamin K in newborns, arrange the blood and blood products, and inform consent to the parents for if there is a need of VP shunting after the post-surgical repair. Now, anesthetic considerations includes all the pediatric airway and age-related pharmacodynamics and pharmacokinetic changes in the pediatric age group. Prone position that is given for the surgery, and the protection of a meningomyelocele during the induction of anesthesia, avoid hypothermia and avoid excessive heat loss, risk of latex sensitization and allergy, and associated hydrocephalus and congenital anomalies. Now, surgical repair includes primary closure of the defect with excision of sac, preservation of a neural tube and dural repair, detethering of the spinal cord if any, soft tissue coverage, and if there is a large defect, there is the surgeon may take rotational flap of the skin, and if required, post-surgical VP shunting. The child is to be placed in prone position on OT table for surgery. And anesthesia technique is general anesthesia with controlled ventilation. Now, position before induction, it is very critical for intubation as well as to avoid the pressure rupture and subsequent damage to the exposed neuronal tissue. Now, in supine position, the sac should be placed in donut, or we can elevate the blankets to leave the defect free. Multiple pillows can be used for kyphoscoliosis or contractures, and shoulder roll for head position with relative macrocephaly or hydrocephalus. Induction, both IV and inhalational agents can be used for induction, but the best are propofol and thiopentum. Thiopentum is the best neuroprotective mechanism and could be used if not contraindicated. Avoid ketamine if there is associated hydrocephalus and raised ICP, and inhalational agents like sevoflurane can be used if the child has difficult airway and congenital anomaly, but it should be avoided in raised ICP because it increases the cerebral blood flow. Now, hence, it is very peculiar for each case that induction should be categorized accordingly. Anticholinergic prophylaxis is must for neonates, and rapid sequence induction should be done. And usually, if there is vocal cord palsy, if the patient has inspiratory stridor and raised ICP, but the risk of aspiration should be balanced against the risk of desaturation if the child has impaired renal functions. Use of suxamethonium that causes hyperkalemic response, and these patients have sensory motor neural deficit, but evidence shows that it does not cause any hyperkalemic response, and it can be used in difficult airway. Otherwise, nowadays, rocuronium could be done for rapid sequence induction. And if the defect is large, the induction can be done in lateral position. Airway management. So for this, because of the difficult airway and pediatric age group, difficult airway equipment should to be kept ready. If you have a video laryngoscope, it will be beneficial because it limits the neck movement in case there is a thoracic or cervical meningomyelocele. Use of armor tube should be used because the patient to be kept in prone position, and nowadays micro cuff tubes can also be used because of various advantages. There are chances of endobronchial intubation because of relatively short trachea in these patients. And after intubation, so ensure bilateral air entry. Other alternatives that are usually various anesthesiologists have done is the platform of rolled blankets with the assistant temporarily supporting the head, or placing the child's head beyond the edge of the table with the assistant supporting the head can be done. And occasionally, if the anesthesiologist is quite confident that he can intubate in the lateral position, that could be done also. Maintenance with oxygen and air. So in this, again, intravenous as well as inhalational agents can be used for maintenance of anesthesia, but avoidance of nitrous oxide and halothane because they both cause increase in ICP. Isoflurane and sevoflurane has a least effect on cerebral blood flow and hence ICP. Mechanical ventilation with low tidal volumes with 6 to 7 ml per kg and maintain the normocapnia. And pressure control ventilation is preferred. Neuromuscular blocking agents, usually atracurium and vicurinium should be used, and avoid if the surgeon demands the use of a EMG, that is electromyography, or nerve stimulator during the procedure to know the functional capacity of the nervous tissue. Intraoperative analgesia can be provided with fentanyl. Recently, fentanyl has been launched, so it can also be used, and PCM. After the induction, the child to be placed prone position, and certain points should be remembered because improper position may lead to venous congestion, leading to reduced lung compliance. Increased abdominal pressure may cause increased bleeding intraoperatively, and if there is a brainstem compression in Chiari malformation because of extreme head rotation, it may lead to raised intracranial pressure, or the patient may land up into bradycardia and apneas. So ensure freely mobile abdomen and head ring to be placed to keep the head in a comfortable position. Avoid excessive rotation of the head. Additional support for limbs and contractures in older children. Eyes well covered by the pads and tape. All the pressure areas should be padded properly, and reconfirm the correct placement of endotracheal tube after giving the position. Standard intraoperative monitoring includes ECG, SpO2, EtCO2, NIBP, and invasive monitoring in hemodynamically instabilities there. Temperature probe to regulate the temperature because the children are more prone for hypothermia. Neuromuscular monitoring with discussion with surgeons, and electromyography monitoring, and recently near-infrared spectrometry that works similarly to the pulse oximeter can also be used if available. Very important, fluid management, because the volume status ensures the adequate spinal cord perfusion pressure and minimize the ischemia. And in these patients, intraoperative third space loss is very high. And in neonates, they are more prone for hypoglycemia, so monitoring of the blood sugar is usually done in neonates. Now, the fluid management includes a deficit that occurs because of maintenance of deficit part, because of dehydration and fasting, and maintenance to support the metabolic needs by the Holiday-Segar 4-to-1 rule, and replacement of a blood loss and third space loss. Now, what type of fluid that can be used in new pediatric age group? It is that any fluid deficit or surgical loss should be replaced by given isotonic saline, and in newborns, the maintenance fluid should include, along with isotonic saline, 1 to 2.5% of dextrose, and newborns 2 to 4% is required. Avoid hypotonic fluid because it will complicate the neural tissue and damage can occur. And there's a German guidelines which were by 2016 is a rule of 10 that background infusion that is should be started at 10 ml per kg per hour, and in case of circulatory or hemodynamic instability, increase the balanced salt solution rate by it should be given to 10 to 20 ml per kg, and volume, that is colloids, could be replaced by 5 to 10 ml per kg, and transfusion also 10 ml per kg. Now recently, goal directed fluid therapy that is used nowadays in adult patient is under investigations in pediatric age group. Estimation of blood loss is very difficult to estimate because the blood is mixed with CSF, irrigation saline, and the surgeon gowns and drapes also can lead to underestimation of blood loss. So don't rely on the methods that are used for blood loss estimation. Watch for vitals, urine output, and peripheral circulation, and also the post-op drains. And appropriate replacement should be done if the surgeon needs extensive flap coverage for the large defects. Intraoperative complication that may be because of during laryngoscopy and intubation, compression of the brainstem leading to bradycardia, hypotension, latex allergy that lead to bronchospasm and cardiovascular collapse, neurological insult leading to immediate postoperative seizures, blood loss, and removal of large defect and sudden loss of CSF may lead to increased craniospinal pressure gradient, and herniation of the brainstem can occur. And because these patients have autonomic nervous system control disturbance, this may lead to hypothermia. So care should be taken in these patients. Reversal after the surgery should be done either by neostigmine, atropine, glycopyrrole, and recently Sagamedex can be used. And after oropharyngeal suction, return of muscle tone, spontaneous respiration, and adequate tidal volume, and the child is fully awake, extubate the patient, and post-operative analgesia can be surgical site infiltration or use of remifentanil and PCM. And the child should be kept in lateral and prone position for healing after the surgery. Post-operative management, shift the patient to ICU depending upon the perioperative condition. Immediate complication, that is hypoventilation and apnea, requires monitoring for at least for 24 to 48 hours. Other complication may be CSF leakage, wound dehiscence because of raised ICP, infection, and hydrocephalus if the shunting is not done in these children. Few words about prenatal surgery that can be done within 23 to 25 weeks of gestation. It is of two types, that is minimal invasive procedures by the endoscopic or USG guided intervention, and open, in which the maternal laparotomy and hysterotomy is done, and anesthesia, uterine relaxants are given, and the surgery can be performed. There is a trial which was done in 2011, that is MOMS trial, in which the general anesthesia and epidural was administered to the mother, and IM fentanyl and vicodinium to the fetus. And it shows that prenatal surgeries have independent ambulation that at 30 months was better, and VP placement was less when the child with that fetus was operated prenatally, but uterine dehiscence and preterm delivery were the complications which were shown later on. And in follow-up at 6 years of age, independent ambulation and mobility of a child was more during prenatal surgery. Role of regional anesthesia, in which there is very limited evidence over there, and there was a study in 1995 in which a spinal anesthesia was given by hyperbaric tetracaine, and the 14 neonates were operated with 100% success rate, and supplementation were given, that is for IV benzodiazepines for agitation if the procedure is prolonged. And only 2 patients had post-operative apnea and bradycardia. But recently, there are no evidence regarding the role of regional anesthesia in this repair. So to summarize, the meningomyelocele is the most common neural tube defect. It is associated with Arnold-Chiari 2 malformation, hydrocephalus, and other congenital anomalies. pediatric patients pose a diverse range of challenges to the anesthesiologist, and hence meticulous preoperative assessment, optimization, vigilant intraoperative monitoring, and anticipated post-operative complication management should be considered. And most important is understanding the pathophysiology will help us to plan a safe anesthesia and improve the surgical outcome. So thanks from the Gitanjali Medical College and Hospital, Udaipur, in the city of Lakes. Thank you so much.
Thank you, Dr. ALKA CHHABRA ma'am, for that very elaborate lecture.
Thank you, ma'am.
And I think, are there any questions? Because you have almost included everything in this short span. I wanted to ask one question. Which endotracheal tube do you prefer? Do you prefer armored tube? Do you use it in units?
Yeah, we are regularly using armored tube, but microcuff, it has advantage that it can inflate the cuff of less than 10 centimeters of H2O that can be used, and it has no Murphy's eye, and the pressure on the trachea mucosa is less, and it is very helpful in using this.
Because this prone position, so microcuff you prefer over the armored, because
I prefer armored cuff now because it has been shown the chances of trauma and the post laryngospasm are less with if you are using cuff tubes as compared to uncuffed tubes. So I prefer armored tube.
So do you have a armored microcuff tube?
No, armored tube is a different, that is flexometallic. Recently, microcuff tube has been launched. It is just came, and many of the anesthesiologists are routinely using microcuff.
Madam, you say ki
Armored.
armored and flexometallic same as that.
It is cuffed. Armored is also cuffed tube in pediatric age group.
Reinforced tube also name it.
They are available.
Yeah, nowadays microcuff is available.
Yes.
Yeah, armor is available. Yeah.
The armored problem is the tube thickness is so much that the internal diameter becomes very small in case of a neonate. If you want to use a 3 size armored tube, the internal diameter would be compromised.
Yeah. Yeah, recently many of the anesthesiologists are shifting on a microcuff.
Micro.
Okay.
Madam, you say saxamethonium,
Yeah.
rocuronium. Can Sugamadex use? Can we use?
Yeah, definitely. Sugamadex is used in pediatric age group, and it has been shown a beneficial results over there.
Okay.
There is a question.
I have not used personally I have not started using Sugamadex in pediatric age group, but I'm using in adult patients. Yeah. Yeah. I am not used now. Yeah, below the age of 2 years, it is controversial. Yeah, it is controversial.
It is not recommended below the age of 2 years.
But some evidence are showing,
some
more
evidences
than 2
are
years,
there.
some are there, but
Yes.
the studies are going on this Sugamadex now.
Yes,
Yeah.
yes.
Any more questions?
Yes.
There are studies published very recently about use of Sugamadex in neonates, but there is no sufficient evidence to say that it can be used safely in neonates.
It's a new drug, na?
They are using it now, so they're doing studies. So yeah, I agree with that. So we have to use it and then publish it. Yeah.
Okay. Thank you, madam.
Thank you,
Welcome, madam. You have elaborated very nicely.
Thank you, sir.
Thank you, madam.
Thank you, ma'am. It was a very informative lecture indeed. I request chairpersons to felicitate our speaker, Dr. ALKA CHHABRA, ma'am. And I request escort committee to escort the chairpersons to the felicitation venue.
Sorry to interrupt, but we are running a bit behind our schedule. So it is request to all delegates to keep your questions ready for the tea break.
I request the chairpersons to felicitate our I request the escort committee to escort the chairpersons to felicitation venue.